Assalamu alaikum and good morning, ladies and gentlemen. Thank you very much, Dr. Sani, for the kind introduction. I also like to thank Dr. Ayman and the MENA group for organizing such a wonderful and fantastic conference, really. Very rich clinical topics. I'd like to welcome you all and also our colleagues who are online. And we all hope that you are here with us today, but it's okay. We understand the limitation and at least you are there with us online. So today I'm going to talk to you about some of the rare disorders of the adrenal gland. We heard really fascinating cases from Dr. Vidya. So I'm a clinical pathologist and a medical biochemist by training. And me and the pediatric endocrinologist, there is a lot of chemistry, I would say, between us. So I may call for Dr. Vidya for some help. So I'll discuss some of the rare congenital adrenal hyperplasias, mainly the 17 and 11 dehydroxylase deficiencies in great details. I also talk about some of the potential pitfall that you may face with the diagnosis of these conditions coming from the lab. And also I will describe the phenotype, genotype characteristics of these rare forms of congenital adrenal hyperplasia. So I will also start my discussions by presenting to you a couple of cases just to illustrate what I want to talk about. So this is a curious case of primary amenorrhea, 16-year-old female presented with primary amenorrhea. She has no previous medical history apart from maybe some vitamin D deficiency and some iron deficiency in the past. And there is no family history of endocrinopathy in her family. On examination, she was found to be normotensive, overweight, about 99 kilos in a 16-year-old. She is tall in comparison to her parents, so about 185 centimeters, and she lacked breast development, no axillary or pubic hair. These were her labs. As you can see, pretty much normal electrolytes, really. But it was noted that her LH and FSH were markedly elevated. And also her progesterone was really, really elevated. And then in contrast, you see that her serum testosterone and cortisol were low. Estrogen were kind of borderline, but one would argue it is also on the low side. So, what is the cause of the primary amenorrhea and sexual infantilism in this case? We'll discuss that in a minute. What is the potential diagnosis given the increase in the progesterone and the decrease in the cortisol? Here is the hint. And what other tests would you order in this case? Stay with us. Okay, moving to case number 2. This is a rare cause of viralization and hypertension. So this is actually a 22-year-old female who was visiting from Tunisia and presented to the emergency department with a decreased level of consciousness. Her friend who was traveling with her stated that the patient ran out of medication a few days ago and wasn't able to acquire them because she thought she needs prescription, and anyways, she just somehow these things didn't materialize in right time. She also stated that the patient had a brother who suffers from the same condition back home. On examination in the emergency department, she was found to be unresponsive. They had to intubate her, really hypertensive. Her blood pressure was 209 over 129. She was short, about 140 centimeters, with features of viralization, so some hirsutism and acne, and so on. And there was some evidence of past genital surgery. Her lab results were marked for severe hypokalemia, in fact, critically low hypokalemia. She also had acute renal failure. Her cortisol was very low, and her testosterone was very, very high. So pretty much opposite to the previous one. Again, what are the causes of hypertension and viralization and short stature in this case? what are the potential diagnoses that we're dealing with, and what has led to this acute and critical presentation in the emergency department, and what other tests would you order? All right, moving gears then. So I'm just going to talk a little bit about congenital adrenal hyperplasia and then hone on to these two rare conditions in a few minutes. So congenital adrenal hyperplasia or adrenogenital syndromes is a group of inherited disorders that are characterized by enzymatic deficiencies affecting the steroids, the adrenal steroids biosynthesis. The clinical and biochemical manifestation really depend about where the enzymatic defect is. But the hallmark of this condition is the low cortisol concentration. This is really the hallmark of this condition. Now, the decrease in the cortisol then will lead to stimulation of the ACTH, which will basically drive the gland crazy, yeah? Because ACTH really working on the adrenal gland, this is why they get the hyperplasia. But the problem is whenever you have a block, the pathway is blocked, and then the adrenal steroids are shifted to the other unblocked pathway. So you have deficiency in the primary site where the block is, accumulation of the metabolites just above the block, and diversion in the pathway towards other pathways, whether it's the androgen pathway, etc., where it is not blocked. So these are the main characteristics, and we'll go about these pathways one by one in a minute. More than 95% of congenital adrenal hyperplasias are because of the 21-hydroxylase deficiency. So this is a very common cause of this condition, and the incidence varies between 1 in 5,000 to 1 in 15,000 live births. In the UAE, it's about 1 in 8,000, and in Saudi Arabia, it's about 1 in 7,000 live births. 11-beta-hydroxylase deficiency is the second common form of congenital adrenal hyperplasia, accounting for about 5 to 8% of cases, with an incidence of about 1 in 100,000 live births. A 17-hydroxy alpha hydroxylase deficiency accounts for about 1%, with an incidence of about 1 in a million live births. Now, there are other very, very rare causes of congenital adrenal hyperplasia, including the 3-beta-hydroxysteroid dehydrogenase type 2 deficiency. This has been reported in Saudi Arabia as well, and they're very, very, very rare cases. There's also the Leadpoint congenital adrenal hyperplasia, cytochrome P450, hexose-6-phosphate dehydrogenase deficiency, and the cholesterol side chain cleavage enzyme deficiency. I'm not going to go all over these things, but I may touch on 2 of them, at least the ones reported in Saudi Arabia and in some cases in Turkey as well. So just to go back to the steroid biosynthesis, you can go back to your physiology and anatomy and biochemistry. So we know that, we have the zona glomerulosa, the zona fasciculata, and zona reticularis in the adrenal gland. Zona glomerulosa produces for you the mineralocorticoids. Now let us see if we can use there we go. So this is the pathway which produces aldosterone eventually. So this is your mineralocorticoids. Fasciculata will produces for you the cortisol, and then reticularis will be producing mainly the androgens, and then the peripheral tissue will convert them to estrogen in females. So the 21-hydroxylase deficiency really is caused by a genetic defect of the CYP21A2 gene. And it, as I said before, it accounts for more than 95% of the cases. It also shows ethnicity and geographical differences. So certain areas, for example, in France, the incidence could be, yeah, it could be as frequent as 1 in 2,000, and also certain area of Alaska as well as almost 1 in 280. And really it is a function of consanguineous marriages and so on, and hence also it is common in our part of the world. So again, from the name, the 21 hydroxylase deficiency. So here again, these are the pathways. This is the aldosterone pathway. This is the cortisol pathway. And this is the androgen pathway. So here you have blockage of the 21 hydroxylase enzymes, which is blocking the mineralocorticoid synthesis. And it's also blocking the cortisol synthesis. So these patients will manifest with manifestation of hypomineralocorticism as well as hypocorticism. Now, the problem here is the pathway which is active then will be the androgen pathway. So the gland, and it is under the stimulation of ACTH hormone, it has blockage here, but then the androgen pathway will be extremely active under the stimulation of the ACTH, and then there will be a lot of testosterone produced. And that counts for the clinical manifestation of this disorder. So because of the mineralocorticoid deficiencies, these babies have salt wasting classically, and they present really in neonatal distress very early on in life because of the electrolyte imbalances. So hyperkalemia and hyponatremia really in basically and metabolic acidosis and hypoglycemia, so really in metabolic crisis. They present very, very early in life. They also present with simple virilization, again, because as I told you, the androgen pathway is really over stimulated. So female will present with ambiguous genitalia, and the baby boys will also present with atypical genitalia. So the non-classic form of 21 hydroxylase deficiency can have different presentation really. It's enough to have at least 1 to 2% of the enzyme activity. And if you have that, children can actually then manifest in different clinical manifestation, and this condition could manifest later in life. The prevalence of the non-classic form is actually as high as 1 in 200. And maybe Dr. Vidya can comment on that if she's seen patients like that in her practice. Most of this form of congenital adrenal hyperplasia is picked up by the newborn screening program because of the increase in one important metabolite, which is here, 17-hydroxyprogesterone. And this is a ton of it. So this is how this diagnosis or this condition is picked up early, and hopefully babies don't have to present in medical emergency to the emergency department. Moving gears then to the 17-hydroxylase deficiency, which is really what I want to talk about today. It is resulting from a defective in the CYP17A1 gene. And the CYP17A1 gene is a microsomal P450 type 2 enzyme that catalyzes 2 different reactions. And maybe it's better to get the picture for you. So it catalyzes the conversion of pregnenolone to 17-hydroxypregnenolone, and also progesterone to 17-hydroxyprogesterone. So as you can see, as a result of this, and also the 17-20-lase, they are usually combined together, you have a shutdown of this pathway and a shutdown of this pathway. So basically, again, your cortisol synthesis is affected, as well as your androgen synthesis is affected, which obviously in females as well will affect the estrogen as well, coming from the adrenal gland. So what happens here is now the pathway is shifted to the production of aldosterone, because this is the pathway which is not affected. So the ACTH stimulation driving the gland crazy, and that producing a ton of mineralocorticoids and aldosterone. So in this case, you will see a lot of progesterone. So again, the progesterone here, because it cannot be converted to 17-hydroxyprogesterone, you have a lot of it. Remember our case with the increased progesterone? That explains why. And then you also have a lot of deoxycortisone and corticosterone. And sometimes, in addition to their mineralocorticoid activities, they also can have some glucocorticoid activities. So these people or these patients may not really manifest with florid glucocorticoid deficiency because of the cross-reactivity. So it has, I'm not going to go into the exons and so on, but there are more than 70 inactivating mutations described in the CYP17A1 gene. And again, they found a founder effect where in certain ethnicities, one mutation or two mutations account for about 82% of the cases, again suggesting a founder effect. And this is primarily in amongst Canadian, Mennonese, the Dutch, Japanese, Brazilian, and East Asian communities. Again, it has the same thing, either a classic or a partial or non-classic presentation. The classic presentation, you get a female phenotype, and because of the increase in the mineralocorticoid production, you get hypertension and hypokalemia, because of the increase of the deoxycortisol. And then there is delayed puberty, absence of the secondary sexual characters, again, because remember, the androgen pathway is now shut down, yeah? So there is no androgen pathway and also no estrogen synthesis on that side. And then there is adrenal insufficiency, but it is not really a feature of the 17-hydroxylase deficiency because, as I mentioned, of the increased corticosterone, which has glucocorticoid activity. The partial form really, again, could present with variable manifestations, variable degree of genital ambiguity, and variable stages of secondary sexual development. So I'm going to go back then to our patient with the primary amenorrhea and the high progesterone. Remember that our lady here. So one kind of abnormal thing here is that she was actually normotensive, which, if you remember, as I mentioned to you the pathways before, the mineralocorticoid pathway is really active. And in these cases, usually expect the blood pressure to be a little bit high, but she was normotensive. The other thing also is that her potassium was pretty okay. She wasn't necessarily hypokalemic. So maybe there was kind of a partial, the angiotensin system is still working, so it's not a complete suppression of the angiotensin system here, but it is funny, but usually cases don't usually follow the textbook description, yeah? But her LH and FSH were both elevated, and this is expected. And as I mentioned, she had tons of progesterone, which was which is basically the hallmark, as well as the low cortisol, remember, and the low testosterone. So she had the ACTH stimulation test. We sent a steroid profile for LCMS/MS, karyotyping. Her ACTH was found to be elevated as expected. And then the ACTH stimulation test failed again to produce a response, mainly because of the blockage in the synthesis. And she was found to be a female karyotype. One interesting biochemical finding in this case is that her level, deoxycortisol, was elevated. Now, this is not expected in this condition. And let me just remind you again with the pathway, because you see, yeah, we have a blockage here. Yeah, so then we are not really expecting at all the 11-deoxycortisol to be elevated. So that was an unanticipated kind of distortion. And this is when a discussion between the endocrinologist and the medical biochemist in the lab is very, very useful. And I'm glad we have Dr. Osama with us here, because this is actually what I will run to Dr. Osama. It's like, what is happening? Things are not adding up here. So there is a phenomenon. It's called the isobaric interferences between these steroids. And when you have a lot of it, these steroids could actually interfere with each other. It's particularly problematic with the immunoassays. And sometimes the cortisol even is overestimated by the immunoassays in children with these disorders because of the cross-reactivity. So you find that the LCMS/MS cortisol level is lower even than the immunoassay levels. And with this isobaric interferences, and perhaps Dr. Osama can elaborate on this more, where the deoxycortisol and corticosterone, which is basically the one which is elevated in our patient, basically come very closely together. So sometimes, if the machine wasn't tuned properly, it actually could it could read this as 11-deoxycortisol, which was in this case. So just a little twist here, and I hope I don't confuse you, but just to instill in you that, sometimes you have to review these biochemical results also with your clinical chemists. The genetic testing was done in this case, and she was homozygous for a disease-causing variant, and basically the biochemical investigation confirmed the 17-hydroxy dehydrogenase deficiency, the classic type. Moving gears to the 11-beta hydroxylase deficiency. Again, this is a rare form of congenital adrenal hyperplasia, and the mutation here is in the CYP11-beta1 gene. As I mentioned, it's about 1 in 100,000 to 1 in 200,000 live births, and it is common amongst Moroccan Jews, where the prevalence could be 1 in 500 to 1 in 7,000, again, because of the founder mutation. And there is a specific mutation that is found again or found in this population. So the CYP11B1 enzyme is again a P450 type 1 mitochondrial enzyme that converts the 11-deoxycortisol to corticosterone and 11-deoxycortisol to cortisol. So let's just go here, and therefore, okay, let's, I think, get the picture better. There we go. So here is again your 11 beta. So deoxycortisol to corticosterone and deoxycortisol to cortisol. So you have a lot of accumulation of, again, deoxycortisol. You have accumulation of 11 deoxycortisol, and then shifting of the pathway to the androgen pathway, which indeed was the feature, and I'll come back to our case again. More than 60 inactivating mutations has been described, and I told you about the Moroccan Jews. Middle Eastern or North African patients also have a specific mutation, actually, which is the Q356X. And remember, our patient was from Tunisia. So that's an interesting one. Clinically, how they present phenotypically, so again, female patients will present with ambiguous genitalia because, again, you have, the androgen pathway is active. And this is why our patient actually, if you remember, had this surgery or evidence of past surgery. While the males will present with precocious puberty, sometimes they call it pseudo-puberty. Because of the increase in the mineralocorticoid, the deoxycortisol production, they will get hypertension and hypokalemia, and postnatal virilization, as I mentioned. And again, adrenal insufficiency is not a feature, again, because of the increase in deoxycortisol, which covers a little bit some of the glucocorticoid activity. Again, with the partial form, you get variable presentation. It could be completely asymptomatic. To that extent, again, you need very little activity of the enzyme to kind of get by. Back to our case then, with virilization and hypertension and this acute kind of syndrome presentation. So it turned out that she ran out of the medication, and the medication she was taking was hydrocortisone. And also we got a history from the friend that her brother had similar manifestations. So this patient obviously came in adrenal crisis and acute renal failure. She's hypertensive. That's in line or in keeping with the biochemical abnormalities, so that's expected. Being short and virilized is because she was exposed to androgen very early on in life, and therefore that led to her premature bone closure and virilization, and also the evidence of the past general history. Again, the hypokalemia is a very common feature of excessive mineralocorticoid secretion. And then her ACTH was a bit funny because initially it wasn't elevated, but on a subsequent sample, it was found to really be markedly elevated. The decreased cortisol and the increased testosterone, again, were hallmark of this case. Now, obviously, because this was an acute presentation and the patient had to be started immediately on steroids, we couldn't do a lot of follow-up testing in this case. However, we had some, or at least in that case report, there was some leftover sample that was sent, and obviously her sample was also sent for genetic studies. Her 17-hydroxyprogesterone was found to be elevated, which is expected. Cortisol is low, as I mentioned to you, and here you notice that the LCMS cortisol is actually lower than her immunoassay cortisol. The disulfate was increased, as well as the testosterone, which is again expected in this case. Sequencing results actually showed a very neat mutation. She is compound heterozygote for the Q356X mutation that I told you is common among North African patients, and also another mutation that led to the classic phenotype manifestation. Her younger brother had the exact same mutation, and he presented with precocious puberty and accelerated growth, but he had no electrolyte abnormalities. Very quickly, moving gears to rarer and rarer forms. Maybe I have 3 or 4 slides on these. So the 3-beta hydroxysteroid dehydrogenase type 2 deficiency. This is a very rare form of congenital adrenal hyperplasia, and actually, I'm just going to go right there. So the block is up there. That is the enzyme which is blocked, and you can see now it will affect everything, and there is no diversion anywhere else. So all these things are so he cannot produce mineralocorticoids, they cannot produce cortisol, and they cannot produce androgens. So really, it's the presentation of this condition really is that of impaired steroidogenesis in general. And the classic form can have severe clinical presentation. But you obviously, again, have usually atypical presentation where there is a little bit in 1 or 2 of the pathways is working. The other very, very rare form, and I think this has been described in Turkey, is the Leadpoint congenital adrenal hyperplasia. Again, I'm just going to go here. This is even worse than the previous one, because what happens here is, you need the cholesterol to move from the inner to the outer mitochondrial membrane for steroid genesis. And for that, you need this STAR enzyme to help incorporating the cholesterol, and then therefore, again, mediating all these beautiful pathways. The hallmark of this Leadpoint adrenal hyperplasia is that cholesterol is actually trapped inside the mitochondria. And this is why it is called lipoid, because the adrenal gland will just have the cholesterol trapped there. The gonads as well, the cholesterol is trapped in the gonads, and females usually present a little bit later or picked up later because the ovaries start to work maybe around 12 years of age or something, but men usually, or baby boys usually, will present earlier. So back to the clinical presentation. Again, when you have a complete absence of this steroid acute regulatory protein, or the STAR protein, it is really almost a lethal condition. But usually you get a partial mutation, and as I mentioned, it is required for the cholesterol transfer from the outer to the inner mitochondrial membrane. And patients typically have severe combined adrenal insufficiency soon after birth or in early infancy, and the male infants will have abnormal external genitalia. As I mentioned, the females will escape a little bit, if they made it to puberty, but then it will become very clear when they hit the pubertal age that they are unable to produce again the steroid, well, the estrogen from the ovaries. And then the non-classic form could present actually just with isolated cortisol deficiency. They have also some interesting facial manifestations and so on, but I'm not gonna go much into it. So in conclusion then, I hope I impressed upon you that the most common form of congenital adrenal hyperplasia really is the 21 hydroxylase deficiency, followed by the 11 beta hydroxylase deficiency. 11 beta hydroxylase deficiency presents with both mineralocorticoids and androgen excess. The 17 alpha hydroxylase deficiency is a rare form of congenital adrenal hyperplasia with variable presentation if patients have very partial mutation, but they usually present with low concentration again of steroids, cortisol primarily, with the exception of progesterone, which you will find basically surprisingly elevated. And then other rare forms include the 3-beta hydroxysteroid dehydrogenase type 2 deficiency and the Leadpoint congenital adrenal hyperplasia. So these are some of my references, and with that I'd like to conclude. Thank you very much for your attention.